Welcome to another lecture in the opioid-related topics series. So today's topic is opioid-induced respiratory depression. So this is Dr. Mobeen Sayed from drbeen.com. Welcome to another lecture in the opioid-related topics series. This series is also done for DEA CME requirements as well. So today's topic is opioid-induced respiratory depression. The area that I want to cover today is going to be strictly the mechanistic aspects of the respiratory depression caused by opioids. I'm not talking about drug interactions. I'm not talking about a person's body habitus that may change the effects of the opioids. So just the mechanisms of opioid-induced respiratory depression. So as we start our discussion, first I'm going to show you the studies that I've used to pull this content together. So here is the first study, importance of the correct diagnosis of opioid-induced respiratory depression in adult cancer patients and titration of naloxone. In here, I wanted to just read this one paragraph here. So let's start with that. Opioids can induce respiratory depression by invoking a centrally mediated decrease in involuntary respiratory rate, which in severe cases can cause a decrease in oxygen saturation. If respiratory depression is opioid-induced, both low respiratory rate and low oxygen saturation will be present. This is an important thing to be able to assess the patient to see, is it opioid related? Normally, when our oxygen levels go down, oxygen saturation reduces, our breathing centers try to increase the frequency of breathing, the volume of breathing, etc. And if the breathing is not increased, rate of breathing is not increased, and oxygen saturation is low, this may be opioid. There can be other reasons too, but if you suspect opioid, then this is important to consider low respiratory rate and low oxygen saturation. Then this is another study, dual mechanisms of opioid-induced respiratory depression in the respiratory rhythm generating network. I'm going to explain this one. It is such an excellent study, and I would actually recommend everyone to give it a read. Very, very important study. And then there are some other studies. This is the dorsal respiratory group and the chapter about that. Then physiology of the respiratory drive, central chemoreceptors, locations and functions, effects of fentanyl overdose, induced muscle rigidity, and then some carotid body related aspects. So with this, let's start with my drawings. So conflict of interest declaration, this is a CME lecture, so I have no relevant conflict of interest. Objectives. So today we're going to talk about opioid-induced respiratory depression, or OIRD, and we will discuss the following. We'll discuss the respiratory center, what it is. We'll discuss the rhythm generation in the respiratory centers. These are the things which, at least at the graduate level, these are not present in the textbooks, or really just one sentence or two. Effects of opioids on the respiratory center, effect of the opioids on the central chemoreceptors, peripheral chemoreceptors, chest wall, and airway. And we will look at the mechanisms of all of these. So first of all, summary. If you can capture this summary, then you actually know the whole opioid-induced respiratory depression mechanisms. So first of all, this is a diagram of a brainstem or an illustration of a brainstem. So respiratory center, these nuclei that I've drawn here, they make up the respiratory center. We'll discuss that in a more detail a little later. But one effect of opioids is the depression or abnormality or abnormal function of the respiratory centers. So we'll discuss that. Then the second aspect is what happens is that as we start, let's say that somebody has opioid overdose and their respiratory centers start becoming disrupted, their body would start building up carbon dioxide and the oxygen levels would go down because of the respiratory outcomes, low respiratory rate. In the brain, we have chemoreceptors that can respond to the changes that happen because of the respiratory depression. Opioids can actually suppress the central chemoreceptors from functioning correctly as well. So as you can see, that not only opioids are going to depress the respiratory center, so they put the person in a respiratory crisis or difficulty, But as a result of that difficulty, when the body starts reacting, and when there is more carbon dioxide and then more hydrogen ions produced, which I'll explain a little later, there are various sensors in the body that would respond to them. Opioids actually suppress those sensors as well. Similarly, we have peripheral chemoreceptors that respond to low oxygen levels. These are in aortic bodies and in the carotid bodies. Opioids actually disrupt the neuronal activity for these sensors as well. Then respiratory muscles or the chest wall start becoming rigid under the influence of opioids. So imagine now that on one hand, there is respiratory depression because of central neuronal disruptions. And then on top of this, the chest wall is also not moving correctly. So the person cannot breathe very well. And finally, the airways, especially upper airways, they tend to collapse as well under the opioid effects. So this is the summary. Respiratory system depression, central chemoreceptor depression, peripheral chemoreceptor depression, chest wall rigidity, and upper airway collapse. They all work together, and this can become fatal. Next, respiratory center. So the first topic, respiratory center. It's an amazingly complex topic, and it is beyond the scope of this lecture to actually discuss the whole respiratory system and how breathing occurs. But to get us a little bit of an idea, in our medulla oblongata, in the brainstem, so brain is connected to the brainstem, then brainstem is connected to the spinal cord. Brainstem has three parts, three major parts. We have the midbrain, then we have bones, and then we have medulla. Of course, behind there is the cerebellum as well. And here we're talking about medullary centers. There are respiratory nuclei that are present in the medulla. There are respiratory nuclei that are present in the bones as well. So the way we look at the respiratory center is we divide it into three major classes. We say pontine respiratory group, or this pons, this is one of the tissues, pontine respiratory group, or PRG. Then in the medulla, there are two respiratory groups, or there are many nuclei, but two major respiratory groups. One is a dorsal respiratory group, or DRG, and then there is a ventral respiratory group, or of course, VRG. Their behaviors are such amazing things. However, the one that I would like you to remember for today in this lecture is the preBötzinger complex, this nucleus over here. This is the primary nucleus that produces rhythm for our respiration. Just like our hearts have a pacemaker, you can call this a pacemaker for respiratory system. Normally what happens is, as right now you're listening to the talk and you are going through quiet breathing, in the quiet breathing, what happens is that we have inspiration that is started by our central system, and then that inspiration effort is discontinued and expiration starts occurring, which is a passive mechanism. What does this mean? What it means is that when you are doing quiet breathing, you're not forcefully inhaling and forcefully exhaling, you're just breathing. In that case, the diaphragm, which is a muscle between our thorax and our abdomen, the diaphragm is pushed downwards, which causes the lungs to be pushed down as well. And as the lungs are inflated, there is negative pressure that is produced in the lungs, and that causes the air from outside to kind of rush in the lungs, and that is inspiration. Then we cut that circuit that is pushing the diaphragm down, and the diaphragm just passively is pushed back up. And when it is pushed back up, the lungs are pushed up as well, and that causes the air to be exhaled, and that is quiet breathing. Interesting over here is that this Prebosinger complex, or Prebosinger complex, this is the one that produces the rhythm for inspiration. This is where automaticity of breathing starts. This complex goes over various phases. We call them refractory phase, then we call it percolation phase, then the spiking phase. For us, it is sufficient to say that with a delay, there is an automatic activity that happens in this nucleus. That activity then causes effect on other nuclei. We'll discuss them a little more later on, but just focusing on the Prebosinger complex, it would then affect those nuclei that would cause the diaphragm to move and we would have an inspiration. Interestingly, can you imagine this part? Listen to this. Once we are inspiring, once we are inhaling, we need an extra nucleus that would cut off the inhalation and stop the breathing. Otherwise, we'll just keep inhaling and would not stop. So here in the pontine area, these nuclei here, pneumotaxic center and apneustic centers, they are responsible for helping to either cut the inspiration to kind of limit that, or even to participate in forceful inspiration. For example, right now, if you decided, I want to have a deep breath, so that forceful inspiration will be helped by the pontine centers. Now, also, I am talking right now, so I'm not doing quiet breathing. My personality area is telling my respiratory centers that this person is talking. He needs a little more force from his chest wall. He needs a little more deeper breath and a more explosive exit of the air. This is called respiratory system modulation. So the respiratory modulation can be done by many other parts of the brain. All of them would eventually connect in these areas and kind of modulate the activity. So for the time being, please keep an eye on Prebosinger complex. Now we're going to talk a little more in detail about the Prebosinger complex. This one area, I had to read a lot of studies to kind of figure out exactly what is happening. So here, this is the Prebosinger complex present in the ventral respiratory group in medulla oblongata. So imagine that this is that nucleus. This nucleus has neurons in it, and these neurons are heterogeneous. That means they are of various kinds. There are two important kinds that we should know. And if in today's talk, if you didn't remember anything else, if you just remembered this, we will be good at least to understand this all. There is a set of neurons present in preBötzinger. We call it preBötzinger, which are automatic. These neurons have a special gene. That gene is OPRM1. OPRM1 gene is expressed in these neurons. And as you can see here, I've made them with a little bit of a, electrical spikes on them and this jittery neuron. What this neuron does is it becomes automatic. It produces signals with a repeated frequency. This is the actual ventilator of our respiratory system. Pre-BOT-C, within that, one group of neurons, OPRM1 plus neurons. Interesting and curious is that this neuron has mu receptors on it, the opioid receptors on it, not only on its body, but also on its nerve terminal, on its end. Not only on its body, but on its nerve terminal. Why does this neuron or this set of neuron, this class of neuron, why do they have opioid receptors on them? We have no idea. What were we thinking to have these neurons with the mu receptors on them? We don't know. But when the opioid is given, when it is taken, one effect that happens, the central effect, is on these neurons. What happens is when the opioids are affecting the mu receptors that are present on the body of the neuron, then the neuronal automatic activity is disrupted. So what happens is the rhythm starts becoming irregular. And not only that, the rhythm generated here is irregular. In addition to that, think about it. This is going to be a double jeopardy now. This neuron, even if it fires, there is also mu receptors present on its nerve terminals. And we have done this discussion in the past that the mu receptors present on the nerve terminal would cause a blockade of the calcium channels. So when calcium cannot enter the nerve terminal, guess what will happen? This nerve terminal, even if it has the neurotransmitter present in it, it will not be able to release that, or it will release that in lesser quantities. So not only the neuron itself is disrupted, whenever it is firing, the possibility of releasing the neurotransmitters for causing the respiratory muscles to work, even that neurotransmitter release is reduced. So in the whole discussion today, this one part I would request you to remember. Prebosinger nucleus present in the ventral medulla has automatic neurons. These automatic neurons have mu receptors on their body and on their nerve end. When the opioids are present, not only these neurons do not work correctly and the rhythm is disrupted, but when they are working, it becomes a challenge for them to release the neurotransmitters because opioids are also reducing the release of neurotransmitters by blocking calcium channels. Now, in the preBötzinger, in the same nucleus, there is another group of neurons that are called quiescence neurons. These are also nerve cells that are present here. These cells can also initiate inspiration, but they do not initiate it automatically. They're not automatic neurons. They are connected in the circuit to initiate inspiration. But for them to initiate inspiration, they need external stimuli. What does that mean? For example, right now, if I said, I want to have a deep breath, so my personality area is going to talk with so many other systems, for example, basal ganglia and the cerebellum, and create a plan to say, I want to have a deep breath. Eventually, that message that, hey, have a deep breath, employ a lot of muscles to do that. For that modulating activity from outside of the rhythmogenic cells, that are these cells, this set will require a signal, a message from other neurons to say, hey, can you please help us create an inspiration? Then this neuron would work just like this one and send the neurotransmitters, which would then cause the inspiration to start working. So this set of neurons are called OPRM1 negative because in their DNA, they do not have OPRM1 gene expressed. So preBötzinger nucleus, many kind of neurons, two important for us, OPRM1 plus and OPRM1 negative. The plus one are automatic. The negative need external stimulus for them to function. So you might say, imagine if somebody is under respiratory distress because of the usage of opioid, and imagine they realize that, hey, I'm not able to breathe correctly, and they try to force themselves to take deeper breaths. That process of voluntarily modulating respiration will involve this neuronal set, the Quiscent set. Why do we call it Quiscent set? Because it by itself is not becoming automatically active. You have to send it a message to become active. And now imagine this person wants to have a deep breath, but the neuron here, the Quiscent set, has mu receptors on it as well. Those mu receptors are present on its body and on its dendrites. The result is that this neuron under opioid effect will become hyperpolarized as well. So when the external systems are asking it to help create an inspiration, it still cannot function very well because opioids are causing it to become hyperpolarized or stabilized or less active. So very important two things. Automatic system isn't working correctly. The system that can voluntarily be affected is also not working correctly. Now, there is another study which was very interesting. They did that study. Now, please realize that, just a quick side note, opioid overdose or opioid-induced respiratory depression type studies are not done on human beings. You can't give somebody opioid and say, all right, let me see what happens to your respiratory center. I want to see the overdose depression of respiratory center. So it is done on animals. Check this out. In one of the studies, they found that just 140 neurons of preBötzinger automatic hub, just 140 neurons, if they are affected by the opioid, the respiratory system is seized. An even more interesting thing that they found in that study was that if you can get 50% of them to be reversed, to start functioning again by, let's say, giving opioid antagonist or naltrexone type drugs, just 50% of them, when they recover, the respiration comes back. What that means is, at least from that study's point of view, you do not have to recover all the neurons that are affected by opioid to resume breathing. Just half of them, when they are recovered, the person would start, or the animal in this case, started resuming breathing. And just the number of neurons, 140. Okay, so I hope that this becomes clear. This is the most important thing for opioid-induced respiratory depression. This is how the depression occurs. Everything else has a milder outcome compared to seizing of this system. Now, I want to read from this study, dual mechanism of opioid-induced respiratory depression in the respiratory rhythm they say our collective results indicate that only 50% of the pre-Bötzinger neuron express the OPRM1 gene and are therefore able to play a direct role in opioid-induced respiratory depression. Yet, respiratory rhythmogenesis is effectively inhibited because opioids act with a double-edged sword to functionally remove OPRM1 neurons from the pre-Bötzinger network. They're saying opioid would act on this neuron or set of neuron with a double-edged sword with double effect. I've already explained that effect. By simultaneously reducing intrinsic excitability and impairing excitatory synaptic communication, meaning the intrinsic ability is gone of the rhythm or reduced, depends upon the dose. And secondly, this neuron's ability to communicate with other neurons to say, all right, let's have a breath, that ability is also depressed. Why? I just explained it. Why? Because mu receptors are here as well, and the calcium channels are blocked and neurotransmitter is reduced, right? So by simultaneously reducing intrinsic excitability and impairing excitatory synaptic communication, exogenous opioids disable the normally robust inspiratory network, leading to long and variable pauses between breaths and ultimately cessation of rhythmogenesis altogether. Thus, interesting yet unresolved questions are as follows, and they have a bunch of questions. I thought this was interesting. Why do these critical rhythm generating neurons express the mu receptors, etc.? Now, that is done. The primary meat of today's talk is done. Pre-Bötzinger neuron, rhythmogenic neuron, double-edged effect of opioid on them, and respiratory depression occurs. Now, once the respiratory depression occurs, what will happen is that we would now not breathe correctly. The rhythm is disrupted. The carbon dioxide would start building up in our body because we are not expelling it that frequently and that easily. Oxygen is reduced in our body. So our chemosensors will become active. So we have two sets of chemosensors in this context. One are the peripheral, which I'll discuss a little later. These are in the carotid body and aortic body. Next slide. The other one are central chemosensors. So let's see what happens. Imagine that somebody is breathing incorrectly. Somebody is breathing with less respiratory frequency. Carbon dioxide is building up in their body. What happens is that carbon dioxide combines with water and makes H2CO3, which then breaks down into hydrogen and bicarb. It's written here as well. This hydrogen is, of course, it's going to cause acidity. The problem is this hydrogen cannot cross blood-brain barrier because it is ionic, but carbon dioxide can cross blood-brain barrier. So the first thing to keep in mind, when our body has increased carbon dioxide as a result of other reasons too, but here in this context, we're talking about respiration. So as a result of disrupted respiration or respiratory depression, when the carbon dioxide is increased, it is making hydrogen and bicarbonate in our peripheral tissue. What do we mean by peripheral here? The central area is the brain and everything else is peripheral. That hydrogen that is produced in the peripheral tissue is not able to go to the central areas and trigger them. But carbon dioxide can easily cross blood-brain barrier as if there is no blood-brain barrier. It just diffuses across it. So what happens is as the respiratory depression occurs, as the carbon dioxide is built up, that carbon dioxide will enter the brain tissue. In the brain tissue, then it will combine there with water, will make H2CO3, and will then break up into HCO3 and hydrogen. This hydrogen will then affect the respiratory centers. So here, if you see in this diagram, I have this tiny little sliver in the front. So about 0.2 millimeter deep on the ventral surface of the medulla, there is a set of neurons that sense hydrogen ion concentration. They say that they can sense carbon dioxide as well, but their major sensation or their major response is to hydrogen ion concentration. So now think about it. The person is not breathing correctly. Carbon dioxide is produced in the body and it is building up. That carbon dioxide goes to the brain, crosses the blood-brain barrier, goes into the brain tissue. Over there, it combines with water, makes hydrogen. This hydrogen can then cause the central chemoreceptors to become triggered. So here I've made that central chemoreceptor area. So imagine that this is sitting about 0.2 millimeter deeper in the medullary tissue. Hydrogen would go and bathe this area, and that would cause, in normal situations, increased hydrogen would cause outflow of neuronal activity from this area, which would cause the ventral respiratory group and the dorsal respiratory group to become activated, and more frequent breathing and deeper breathing would occur. That is a normal behavior. So if you hold your breath and let carbon dioxide build up, eventually that carbon dioxide will enter the brain and then go make hydrogen ions and then trigger the chemoreceptors there, and that would then cause the inspiratory systems or respiratory systems to become activated, and they would then want to give you deep breath and frequent breath. Guess what opioids do? So you might be looking at this and say, okay, so we have a solution here. If there is an opioid-related respiratory depression, then maybe this system would kick in and it would help cause the breathing to get back towards normal. But opioids have another trick in their mind. What they do is they depress the neurons present in the central chemoceptor area as well. So we are not breathing correctly. Carbon dioxide is building up. In the brain, that carbon dioxide is causing acidity. That acidity is sensed by the neurons, but those neurons under the influence of opioid aren't functioning correctly. So we can't now bet on the central chemoreceptors to rescue us and give us breath because opioid is suppressing them as well. Okay? That would result in depression of the ventilatory response to increase carbon dioxide. So we say increase carbon dioxide, but as I explained, it actually is hydrogen ion. We do not respond to peripheral hydrogen ion as powerfully as we respond to the central hydrogen ions. The reason, it's a very interesting reason. Number one, hydrogen ions cannot cross blood-brain barrier. Number two, you could say that, well, we have chemoreceptors in the periphery as well. Maybe there is some hydrogen sensors. The problem is that hydrogen that is being built up in the peripheral part in the body, that is diluted in the whole body's fluids. But this hydrogen that is being produced in the brain, that is concentrated in a very tiny area, the brain. So that has a more powerful effect on this central chemoceptor. Plus, we said that hydrogen cannot cross. So peripheral hydrogen cannot go to the brain. Peripheral hydrogen can only work peripherally, and that doesn't have a powerful effect. So now we know two things. Number one, rhythmic or rhythmogenic respiratory hub is disrupted under the influence of opioid. Number two, the reaction of the body is also suppressed because the central chemoceptors are not working correctly. They also have opioid receptors. They are suppressed. Okay, so you say, fine, we still have the peripheral chemoreceptors to work. They will come in handy. They will help with the rescue of the respiratory system. So let's look at them. In our periphery, that means in the body, we have chemoreceptors of many types. Renal system has chemoreceptors, other areas have chemoreceptors. In the context of today's discussion, we are talking about two important chemoreceptors. One are present in the roof of arch of aorta. So as the blood comes out of the heart from the left ventricle, it enters the aorta. And so this is the aorta. In the aortic arch, there are special chemoreceptors present that measure low oxygen levels. So it is hypoxia-related chemoreceptor. It's not measuring carbon dioxide. It is not measuring hydrogen ions. Instead, it is measuring lower levels of oxygen. Then, a more powerful peripheral chemoreceptor area is carotid bodies. Carotid bodies are, so as we come out, the arch of aorta, as that comes out of the heart, there are blood vessels, carotid arteries, that are going to go and bathe our head and neck area. Carotid arteries near the angle of the jaw, they divide into internal carotid and external carotid. So we say a bifurcation occurs, a division occurs. At the division, there are specialized cells present. We call them glomus cells, which make up carotid bodies. These are also sensors for oxygen. And it is interesting how do they work. So let me just very quickly imagine that this is a cell. This cell has a channel on it, potassium channel, that has oxygen receptor on it. It can sense the concentration of oxygen. And based on that, this channel can close or open. So when there is less oxygen, this channel closes down. Potassium cannot get out of the cell. Potassium is trapped inside the cell. The cell becomes hypopolarized. The cell becomes activated. The activity that is generated in the cell will then be relayed to the medullary respiratory systems. You might have one more very interesting question. You might say, you know what, here, let's say this is the carotid body, sensory system for oxygen. It is made up of cells as well, correct? So when it is made up of cells, these cells are also using their own oxygen. They need to survive and they need to eat up oxygen as well. They need to consume oxygen. So if they are consuming oxygen, they will be producing carbon dioxide. And if we have a sensor for oxygen over here, that sensor will become disrupted because these cells are using their own oxygen. What is going to protect us from that? Why maybe these systems will be causing false signal because they are using up oxygen? And here is the answer. This tissue, carotid body, receives 20 times the volume of its tissue, 20 times more oxygen per minute. So we give it so much blood that it brings in so much oxygen to it that even if these cells use some of that oxygen, that is not sufficient to create venous oxygen pressure over here. It's always arterial pressure. So you can always measure oxygen here. What a wonderful system our body is. So this carotid body and this aortic body over here, these guys, they are sending messages to the medullary respiratory group. So exactly where and how? From the arch of aorta, the vagi, the vagus nerve, is the one that brings the message to dorsal respiratory group. The dorsal respiratory group present in the medulla is also called inspiratory group. Its total job is to start and help with inspiration. Not start, but to help with the inspiration. The neurons that are coming out of dorsal respiratory group, the outflow neurons, the motor neurons, these go and connect with the muscles in the chest walls, diaphragm, intercostal muscles, and when they are activated, they cause inspiration to happen. So you might have a question over here. You might say, well, didn't we just talk about the preBötzinger nucleus to be the one that starts the inspiration? So now we are saying dorsal respiratory group is responsible for inspiration? Yes, this one, prebot, is responsible for automaticity. When it creates a signal, it sends the signal to the dorsal respiratory group, and then it is the job of the dorsal respiratory group to be connected with the respiratory muscles to cause inspiration to occur. So this dorsal respiratory group is also connected with the peripheral chemoreceptors through vagus nerve, that is the aortic body, and the carotid body is connected through glossopharyngeal nerve. These nerves come in the medulla and they relay on a nucleus called nucleus of tractus solitarius. The nucleus of tractus solitarius contains the dorsal respiratory group. We say that within the nucleus and ventrally surrounding the nucleus are the set of nuclei that are responsible for inspiration. So mind it, I'm not saying they're responsible for automaticity, but when they are activated, they would cause the activation of muscles that would help with the inspiration. So you would say, you know what? This peripheral system will, of course, measure that oxygen is less in the body. And as a result, it will become activated. It would send a message to the dorsal respiratory group and activate it. And then dorsal respiratory group will activate the muscles and all good. We would start breathing. Guess what? The sensors, the neuronal bodies here in these sensors are also depressed by opioids. So on one end, opioid is disrupting the rhythm, causing respiratory depression. On the other end, the sensor systems, alarm systems, and the emergency rescue systems are also switched off. So off in the overdose, of course, this all depends upon the dose. How much is the dose? There may be just simple slight depression of respiration without any switching offs. And there may be a fatal switch off. So central respiratory group, prebot C, rhythm system is gone, depressed. Central chemoreceptors aren't working correctly to rescue us. Peripheral chemoreceptors in aortic body and carotid bodies aren't working correctly to rescue us. Nobody's coming. Our own body is not able to fight back. The fight back mechanisms are disrupted as well. Then what happens next? The chest wall rigidity occurs. What does that mean? So our chest, imagine that these are ribs. Between the ribs are muscles, intercostals. There are external intercostals and internal intercostals. These are the muscles that would help us breathe. They are the ones that would push or pull the ribs. Just observe yourself when you take a deep breath. What happens is the ribs kind of are elevated. When they are elevated, the sternum that is in the front, that is also elevated. And so anteroposterior diameter changes. This is called pump handle movement. And as the chest becomes expanded anteroposteriorly, the lungs expand as well, and negative pressure occurs and the air goes in. And please mind it, today's talk is about the opioid actions and not the breathing mechanisms themselves. Similarly, when these ribs are pulled upwards, they also move up from side to side, and they would expand the side to side diameter or volume of the chest as well. And that would also open up the lungs, and that would also create negative pressure in the lungs, and we would then be able to breathe in. Then below the lungs is this big muscle, diaphragm, and that diaphragm muscle would descend, pulling the lungs and with it and opening them. So there are three volume changes. Vertical volume change because diaphragm has descended, anteroposterior volume change because sternum has kind of pushed forward when the ribs are moved up by intercostals, and side to side volume is changed because intercostals have pulled the ribs up. That is called bucket handle movement. The result is the chest cavity expands and the lungs expand and the negative pressure occurs and we get air. Opioids, as we know as well, affect the muscles too, and they relax the muscles. So this whole musculature over here, which is the final machine that causes the breath to occur, that is a mechanistic aspect of breathing, that machine has relaxed. You are expecting the diaphragm to move so that the lungs can be descending and they can be, vertically increasing the volume, but diaphragm isn't moving that much. You are expecting the intercostals to move to increase the volume of the chest, but intercostals aren't moving that much. So the chest wall has become rigid. Chest wall isn't moving. Even if the person is now struggling to take a breath, chest wall isn't moving that much. So the person is not going to be able to have a deep breath. And so that rigidity also contributes to further aggravating of the situation. These all the mechanisms together produce the final respiratory depression. Okay, last part for today's topic, upper airway collapse. And this is variable in various people, depends upon what is the situation of their upper airway, what is the other diseases or other sleep apnea-like situations, etc. But the pharyngeal muscles, so if you just visualize for a second the back of your throat, so there are muscles that are they are kind of funnel-like muscles present in the back of the throat. They are pharyngeal muscles. Pharyngeal muscles relax as well. Why do they relax? The excitatory outflow to the pharyngeal muscles from the brain is also compromised. So these muscles tend to relax and collapse on each other, which causes obstruction of the upper airways. And if somebody already has a condition for obstruction, then that can become aggravated. So how many mechanisms will come together when an opioid overdose like situation would occur, or when opioid in enough dose are taken that the respiratory fatal or dangerous respiratory depression can occur? Opioid can cause respiratory depression, and people do not just die with every single respiratory depression that occurs. However, depending upon the dose and the body's condition, a person can die as well. So think about this person who is in this state. What is happening to them? Number one, their central system that produces automatic rhythm of respiration, that specific system is attacked. The preBötzinger, the pacemaker of respiration, the rhythmogenic hub of respiration is suppressed. That itself is suppressed. First negative outcome. Then the body tries to react. Body tries to fight back. The central chemoreceptors are one of our rescuers, and they are not functioning. Opioid has suppressed them too. Then the peripheral chemoreceptors in aortic body and in carotid body, They try to fight back, but they are suppressed as well. Then the chest wall, even if we try to take a breath, the chest wall is rigid. And then on top of all of that, the upper airways are collapsing as well. So this is the background to the opioid-induced respiratory depression. Of course, as we continue to move forward in our talks, we'll talk about how to counter them. Naloxone is a drug that is given as an antagonist. So we'll talk about how these crises are then managed. So this is the discussion. Thank you very much for watching, and I would see you next time too.